So this morning we're going to have a webinar where we're going to hear some of the research that the Muskie School of Public Service has done for us. SAMS had asked the Center for Learning to do a comparison looking at other states' processes for training and certification for mental health case managers. And they did that, kind of did a broad scan and then did a deeper dive within some select states. And so this morning, Kimberly Snow from the Muskie School is going to present this information to us. We ask that you all mute your phones, which is *6 to mute your phone during the presentation. At the end, we'll have some time for comment and questions, and you can unmute as you're talking. But in the meantime, during the presentation, you'll see the chat box, and you can put questions or comments as they come up and type those during the presentation, and we'll have a discussion at the end. But at this point, I'd like to turn it over to Kimberly to share this research with us.
Great. Thanks, Letitia. It's good to be here. Hello, everybody. Earlier this year, the department did ask the Muskie School to conduct a review of how different states certify their mental health case managers, or what we in Maine call community integration specialists. Other states use different terms for these providers, including case managers, behavioral health technicians, or community support workers, and states vary in their definition of what services are to be provided by this type of worker. Some follow the federal definition of targeted case management, like assessment, linkage, monitoring, and follow-up, while others describe case management as a key part of providing person-centered, recovery or resiliency-based behavioral health care, where case managers actually provide services such as modeling, education, and crisis intervention. I'm happy to present some of the key findings of our report. The webinar won't be an exhaustive description of how the different states certify their workers, but it will highlight some important differences and similarities across programs. Next slide, please. Our process of review entailed a web-based literature search of provider manuals and state regulations of 34 states. When we found a state that seemed similar to Maine or had an interesting approach, we followed up with email contacts and phone interviews with state mental health departments or accrediting agency staff to get a good picture of how the certification process worked. Next slide, please. We were looking for states that either had a clear certification process, provided services that were similar to Maine in that they were more involved than the typical targeted case management functions of assessment, planning, referral, etc., or required case managers to meet competency or training requirements, or programs that were of specific interest to the department. For example, as Maine has been moving toward the health home model, New York and Rhode Island were of particular interest because they have already implemented their health home programs. Next slide, please. When we were looking at the different states' regulations and provider manuals, we were interested in the following questions. Who oversees the process? Is it a state agency, an outside agency, or a provider agency? Are there minimum education requirements, such as a GED or bachelor's degree? Are there work requirements that must be fulfilled before certification? Is there specific coursework, like certain classes that have to be taken? And if there are certain courses, how many hours do they take? We wanted to know if there are specific competencies that have to be demonstrated, such as administrative knowledge, cultural sensitivity, knowledge of treatment options, etc. And lastly, we wanted to know if there are continuing education requirements for case managers once they are certified. Next slide, please. Based on the answers to these questions, out of the 34 states reviewed, we found 10 that presented interesting comparisons to Maine's certification procedures. They are Alaska, Kentucky, Missouri, New Mexico, New York, North Carolina, Oklahoma, Pennsylvania, Rhode Island, and West Virginia. So we were really all over the map. Next slide, please. And just so you know, Maine is not alone in reviewing how case managers are certified. In our follow-up conversations with the 10 comparison states, we found out that Kentucky, New Mexico, and New York are actively reviewing their own certification processes, and they were quite curious about what other states were doing as well. Next slide, please. And here are our findings. The following slides are a little dense, and not surprisingly, with 10 different states, we get 10 different ways of doing things. I've tried to simplify them as much as possible, and the slides will be available after the webinar. Next slide, please. States use different approaches to administering the certification process. Kentucky and Oklahoma take charge of the process within their departments of mental health. Alaska, Pennsylvania, and Rhode Island are like Maine in that they use an accrediting agency to administer the process. And 5 states, Missouri, New Mexico, New York, North Carolina, and West Virginia, rely on the provider agencies themselves to document that their case managers meet certification requirements. Providers need to keep records of training activities and produce them for inspection if the state asks for them. New York is a special case on this list because it has gone to the health home model of service delivery. New York's health homes started in 2012 and incorporate both physical and behavioral health care. Prior to the health home model, the state had both education and work experience requirements for its case managers, as well as caseload limits. But these requirements are no longer in effect. It's the health homes that are charged with assuring that care is coordinated, but there aren't any state requirements for the health home personnel. Because there are no more official requirements, you'll see that New York doesn't appear on most of the charts in this presentation. But my contact in New York said that they are trying to reinstate some of the regulations, especially caseload requirements for people who work with high-risk individuals. With the introduction of the health home, many more people became eligible to receive care coordination services, and the state is concerned that the higher caseload may impact the ability to provide these services. Rhode Island, on the other hand, has also moved to a health home model, but it still requires case managers to complete a statewide training curriculum and be evaluated by a supervisor at the provider agency before being certified by the Rhode Island Certification Board of Community Support Professionals. Next slide, please. 6 states, including Maine, require at least a GED or high school diploma as a starting point to certification. 3 out of the comparison states require an advanced degree beyond the GED or high school diploma. Missouri and Rhode Island don't specify any minimum education requirements, but we'll see on the next slide that they both have minimum work requirements as a starting point to certification. Next slide. As you know, Maine does not require work experience as a pre-qualification for people who only have a GED. A person with a GED can take all the required coursework for full certification. But some states do require work experience as a qualification for being a case manager. You can see the states listed on this chart have a wide range of work experience requirements for people with the minimum education level. I think it's interesting that Rhode Island and Missouri don't specify minimum education requirements, but they both require a level of work experience. Rhode Island has the least work experience required at 6 months, and Missouri has the most at 4 years. Now, it's likely that a provider agency will require a minimum level of education in those states, but there isn't a regulation for it coming from the state level. Most of the states allow applicants with more advanced degrees to have less work experience than those with lower education levels. As an example, in Missouri, if you have any 4-year degree, you only need 2 years of qualifying experience to become what they call a community support specialist. And if you have a bachelor's degree in a human services field, you don't need to have any work experience prior to becoming a community support specialist. Next slide, please. 8 states, including Maine, specify a number of hours of coursework or training that must be completed for certification. Most of these states have a combination of online or classroom options to meet the requirements. As you can see, Maine has the highest number of hours of coursework to be completed by applicants who have the minimum education level. Up to 150 hours can be waived with relevant work experience. But even if an applicant receives all waivers available, Maine still has the highest number of coursework hours required. Kentucky requires completion of an online self-study course plus attendance at a one-day face-to-face training that is offered in both eastern and western parts of the state. Oklahoma has a combination of online and face-to-face classroom trainings for its higher-level case managers, but it's for its first-level case managers, for which a GED or high school diploma is the minimum education level required. The state only provides 2 days of face-to-face classroom education. These training sessions are scheduled at different times of the year at several different locations across the state. Rhode Island requires completion of a 20-week set of classes provided by the Rhode Island Council of Community Mental Health Organizations. The training program is generally offered twice a year. Next slide, please. Of the states that require specific coursework, there is wide variation in how many hours are required. Maine, Alaska, Oklahoma, and Rhode Island each require specific coursework for certification. As I mentioned earlier, Maine allows work experience waivers of up to 5 of the courses. Next slide, please. Both Maine and Alaska allow applicants with higher educational degrees to complete fewer hours of coursework for certification. However, in Maine, unless an applicant has a degree from a specific program in Maine, the 300 hours of coursework is still required. Next slide, please. Of the 10 comparison states reviewed, we found that after a case manager is certified, 6 of the states require them to have continuing education, although some states were more specific than others about what this entails. For example, Alaska has the highest number of continuing education hours required and also specifies particular classes, namely the National Association for Alcohol and Drug Abuse Counselors courses on ethics and confidentiality. Maine does not have any continuing education requirements. Next slide, please. Of the states reviewed in the project, 3 present interesting comparisons to Maine, either for their similarities or their subtle differences. They are Alaska, Missouri, and North Carolina. Next slide. Alaska's certification process for what they call behavioral health technicians is probably the most similar to Maine's community integration specialist certification process in that it uses an accrediting agency and requires a substantial number of hours of coursework. But in addition to the required 127 hours of coursework for applicants without an advanced degree, Alaska also requires 100 hours of practicum experience and for applicants to be evaluated for competency in what they call foundations of the discipline, as well as professional practice dimensions. The disciplinary foundations are understanding addiction, knowledge of treatment options, applying that knowledge to practice, and the applicant's professional readiness. The professional practice dimensions encompass more of the practical aspects of performing case management, such as performing a clinical evaluation, planning the treatment, making referrals for service, coordinating the services, providing counseling to an individual, group, family, or significant others in the client's life, providing client, family, and community education, documentation, and professional and ethical responsibilities. To become certified as a behavioral health technician, applicants must produce a portfolio of documents including evidence of coursework completion, a statement of understanding ethical practices, supervisor and employer recommendations, and a practicum evaluation form that details the number of hours the applicant was supervised on the competency areas and how the applicant was rated, either developing, proficient, or exemplary on these different dimensions. And as noted earlier, Alaska also requires 40 hours of continuing education every 2 years. Next slide, please. Missouri has an interesting approach in comparison to Maine. It describes its community support specialists as providing recovery or resiliency-based services that are focused on helping consumers acquire skills, access resources, and learn how to manage their illness in order to live successfully in the community setting of their choice. It does not specify any coursework, and it relies on the provider agencies to do the credentialing and training, but it does specify key competencies that case managers must have for both administrative and service delivery functions. What Missouri calls core competencies are more administrative in nature and include knowledge of the provider organization's client population, and understanding of job assignments, regulations, and safety protocols. The service competencies focus on the actual delivery of case management services, such as operating from a person-centered, recovery-oriented approach, understanding cultural differences in the population, delivering evidence-based services, respecting the client's unique needs, and effectively using strategies for engaging and maintaining the relationship with the client. The provider agencies have discretion to plan the training process, but case managers need to demonstrate the administrative core competencies within 30 days of hire, and then they have to demonstrate the service delivery competencies within 6 months of hire. Missouri does not specify the number of hours necessary to train on each of the competencies, but it has developed a webinar on the service competencies that providers can use as training material. The webinar lasts approximately an hour and 20 minutes and has a 20-question post-test. Next slide, please. As I said earlier, Missouri does not have a particular education level required for community support specialist applicants, but it does have work experience qualifications for those without an advanced degree. Qualifying work experience includes a combination of providing one-on-one or group services with a focus on rehabilitation and recovery or resiliency, teaching and modeling how to manage psychiatric and substance abuse issues and using natural resources, supporting the client to find and maintain employment, and assisting clients to achieve their goals. Next slide, please. I chose to highlight North Carolina because while it differs from Maine in that it relies on provider agencies to ensure that case managers are trained, its community support team services resemble Maine's community integration specialist services. In North Carolina, community support team services are designed to reduce psychiatric or substance abuse symptoms and encourage stability, restore the client's community living and interpersonal skills, provide crisis management, and ensure linkage to community services. The services are provided using a team approach in the client's living environment and can include individual therapy, behavioral interventions such as modeling, substance abuse treatment, development of relapse and disease management strategies, psychoeducation for the client, families, caregivers, and others, intensive case management, and arranging for psychological and psychiatric evaluations. So you can see how many of these services are similar to Maine's complement of community integration services. Next slide, please. The provider agencies in North Carolina do the credentialing and training, but the state requires specific competencies for the case managers and community support staff, and it specifies the number of hours that need to be devoted to the training in different competency areas. For staff providing targeted case management, the agency must document at least 24 hours of training in the topics listed here. And for staff that are part of a community support team, 54 hours of training is required. The agencies have discretion as to how to train their staff, but the number of hours required is specified in state regulations. Provider agencies must have policies, procedures, training, and supervision plans that reflect staff competencies, including case management assessments, person-centered planning, linkage and referral, monitoring and follow-up, and professional responsibility. So you can see that North Carolina is somewhat of an in-between model that gives training and credentialing authority to the providers, but it specifies what goes into the training and how many hours have to be devoted to it. Next slide. And in conclusion, we found that states employ different methods of training and credentialing their mental health case management workforce, relying either on department staff, outside agencies, or provider agencies to manage the process. While there's little uniformity in the methods used, there's a common theme that case managers have competencies not just in the administrative functions of case management, but also in direct interaction with consumers to ensure that services meet their needs. And with that, I'd be happy to address any questions you may have. You should know the full report is available on the SAMS website and the web links to the various agencies and reference documents we reviewed. Thank you very much.
Thanks so much, Kim. We really appreciate that. And Julia is now pulling up, and you'll see on the screen the email address for comments and questions that you can use throughout this whole redesign process. but also the website, the newly established website for the redesign initiative, and the report is posted there. That link was also sent out to you in the invitation. As you can see through what Kim shared, there is quite a variety out there, and we didn't delve into this research to find, okay, where's the state that we just want to follow? We really wanted to inform the process and see what else is happening out there throughout the nation. So if you have questions or comments about what you've heard, don't forget to do *6 or #6 to unmute your phone and you can comment. I would really encourage you to take a look at the report, especially there are some matrices at the back of the report that don't do well on a PowerPoint, so we couldn't really show those in a PowerPoint, but they're a great way of capturing some of the information going kind of state by state, looking at some different elements. So, thoughts, comments, questions? Are there things that you heard that you're curious and would like to know more about? We might or might not have the answers, but we can always try to get more information about particular things.
Hello?
Good morning.
Hi, this is Ed Blanchard at Shalom House. We had some staff attend the meeting up in Augusta last week or the week before for discussion around the MHRTC. And I guess they came away not clear sort of the direction the state might be heading in. I guess to repeat our concerns, accessing some of the classes for people who have a provisional A and B is difficult. So is there any kind of planned direction in changes the way Maine is doing it, or are you still assessing and looking at that? And I guess that's just my general question.
Sure, thanks, Ed. We are still assessing. We don't have definite directions, but obviously one of the concerns we have is increasing access. And I think, one of the things that the report highlighted is that Maine really has the most stringent requirements as compared to any other states. We're not saying that we want to just kind of throw the baby out with the bathwater, but this initiative gives us an opportunity to really look at what are our needs in a changing field. What are the needs? How do we best get there? And how do we make sure that we have individuals who are moving into the workforce who have access to then become qualified providers,
Right.
provide quality service. So, I know that's not a specific answer, but we really haven't come up with concrete ways. That's why we're engaging with stakeholders to get input. Part of why we wanted to share this information.
That's good. At least to hear that one of the concerns is access. If we might make that easier or more courses, or I heard some states even the providers provide the training. But I think it's the access that is concerning. It's hard to hire MHRTCs, people we think are really quite qualified, but it's going to take them a lot of work to get their C. Anyway, those were my thoughts. Thank you.
Thanks for that. And we have a couple of comments on the chat too. Mark Kavanaugh said, I think we're doing pretty well, particularly in terms of the education requirements. So looking at comparing to other states. There's a question from Andrea Mooney. Is there some kind of requirement related to consent decree that we have to consider? And we do have some requirements related to consent decrees that, obviously we will need to continue to meet, and we will be keeping those in mind as well. as, so there are a multitude of factors that we'll be having to address as we move forward, which is why let's be thoughtful and careful in this process, but we also don't want to make it too long of a process that it takes years and years. We really are looking towards an implementation plan at the end of this fiscal year, and hopefully having some things that, short steps that we can move ahead on and begin implementing the longer term steps. Looks like a chat back and forth between Mark and Andrea about that. So Andrea was thinking more about it while looking at the slides about other states and what they do or require. So, and it's interesting, we don't know what other states have in terms of consent decree type requirements. But, I think we will just continue to make sure as we move forward, that we're in compliance with those needs. So Kim Lane has asked, did the states have a check and balance as to someone monitoring ethical practice?
I don't have a clear answer to that. I didn't see specific regulation on that. Alaska has those continuing education requirements about taking a class on ethics every 2 years, and there were other states that specifically require ongoing education about ethical practice, but I did not see a check and balance type system in any particular state.
Thanks. We've got some more people typing. Was there a peer component?
I did see in a couple of states where they do allow a peer counselor type person to provide case management, and they do have a certification process. It's almost separate from the regular process. I think it's North Carolina that has the peer component, and I can certainly look into that and get back to you on that.
So yes, we can do a little more research about that. So, and there's a related one about peer support. In going with the social change of traditional mental health, I humbly think that coursework and intentional peer support should be implemented. And so she's put the link here for more information. It's intentionalpeersupport.org. And then Mark has also put up a question. I'm of the understanding that content areas were defined by the consent decree. If we add additional content to the curriculum, will it fall under the mandate of the court? Adding additional components wouldn't make that a part of the consent decree. So, think in terms of how the field has evolved. I think the whole focus on integrated physical health and behavioral health care is a good example of that. When the consent decree began, that was really not on the radar. That's not what people were talking about. But as we're moving forward, are we seeing that that's something that's really important to people's lives as they're moving forward in recovery? Absolutely. So, again, it's that check and balance of looking at, what are our consent decree requirements? How is the field changing and moving? And, as necessary, as we move through this, we would be in conversation with the court master. So have another comment. Ethical practices, boundaries varies greatly between agencies in Maine. We have case managers coming from other companies that worked under very different boundaries than we implement. Sometimes standards may be helpful in that area. So thank you. And that's a good comment. So, you know, looking at some states that there was much of the training provided by a provider, and sometimes there were some standards set by the states and sometimes not. And so it sounds like that comment is that there might be certain areas that it's good to have some overall standards. Is that kind of what you're leaning towards, Catherine? Yes, okay. So, and, you know, along those kinds of lines, we welcome your input on if there are particular areas that it's good to have some overall standards. We definitely welcome that input. Okay, there's another one. It evolved in the consent decree, but the actual coursework had more to do with transitioning patients from AMHI to community. Mike DeSisto used the Boston University model for educational requirements. Grace Leonard. Thanks, Grace. And good point. And I think, you know, that again speaks to that evolution. So, and we don't work in a stagnant field, you know. Fortunately, we're continuing to learn and grow. Other thoughts? And you can unmute your phone if you want to, if you don't want to type to make a comment.
Hi, this is Liz Bailey from Sweetser. Can you hear me?
Morning.
Hi. I'm just thinking more about the ethical points that have been made. If there is a way to sanction or remove an MHRT credential once it's been earned, I'm not aware of it, and it can be somewhat handicapping. It's obviously disciplinary action, say at a out of agency level, is not something anyone would undertake blithely. But there have been a couple of times when I have had some frustration because if somebody doesn't behave, you know, in a really colossally, if they behave in a colossally poor manner, there's not a way that I'm aware of to kind of protect other agencies from employing that person in a way that you can, say, if somebody's an LSW, by reporting them to the social work board.
Thanks. Now, there is on the, it's really kind of a bad apple registry, and it's on the Division of Licensing and Regulatory Services, DLRS website. It's the ALMS, and we can actually put some information up on our website. We've done some information before, but, you know, I think you're raising a good point of the MHRTC being kind of good for life. You know, at this point, you know, you earn it to begin with, and that's all that's required of you. There are no further requirements, and so this is an opportunity for us to look at that and make some changes. So there's a couple more. Kelly Brown said, Grace, I'm curious, are you speaking of the Boston University Workbook Specialized Group? And then a couple of other, so that we really need some input in. I'm trying to track down which was Liz's. Oh, that was Liz on the phone. Yes. Yeah. So kind of a ditto comment with that. We've got a few of those. I think there needs to be some accountability related to certification. So, okay. Can you explain how someone gets put in the ALMS website? Is there a gap of time between when a report is made and when they would appear? I'll have to check to find out what that gap in time is, but, you know, obviously with anything, once a report is made, there has to be some of that due diligence to look into it before. It's kind of that substantiation process. And so we can definitely put some more information on the website about that. I think that's an important link with this work. Thanks, Lori. Any other thoughts? Were there any things that you heard from states that you thought, that's an interesting concept. Maybe we should look at that here in Maine? Or things that you thought, we don't want to look at that part?
Well, this is Liz Bailey from Sweetser again, and I must admit that I was really struck by the amount of coursework, how it compares to that of other states, even if you employ the waiver. And I think, for me, that really speaks to some of the difficulties as an employer of finding and moving people through the educational system. As you have heard several times, it's very challenging.
Right, right. Thanks for
And
that.
before we end the call, can you kind of fill us in about the next steps?
Sure, sure. Okay, we've got a couple more comments. As far as access is concerned, Grace Leonard wrote this comment: all MHRTC courses are offered online, ITV with delayed viewing to enable students to complete coursework in their time, not ours, through UMA. And Mark Kavanaugh said KB is offering the entire 10-course sequence online every semester too. Good access at UMA and KBCC. There's a few more people typing. It's great having online options. And that's one of the things that we recognize, that in our changing world, not only is the field changing, but we're becoming much more technologically inclined as a society, and online options is a huge growing movement. So, and Jewel wrote, USM has a few MHRTC courses online as well at UMF. I'm concerned about how this process coordinates or doesn't, this is another comment, with other existing professional degree programs. At the recent in-person meeting, a participant noted that professional undergraduate and advanced degrees have their own credentialing processes, and this risks becoming a double-layer process for students, presenting a real burden, or has to be built into existing curricula that may need to focus on other skill areas, for example, diagnoses, therapy techniques. Good point. Thank you. I'm going to read that one. We have another comment from Mark Joyce. In 2006, the department acknowledged that there was no authority or ability for MHRTC's certificates to be revoked or suspended, and they were discussing the creation of a registry for MHRTCs who have been substantiated for abuse, neglect, or exploitation. I don't think that registry is for MHRTCs. I believe it's for direct care workers, and that's correct, and CNAs, but MHRTCs can be added to that. And the vast majority listed on the website are CNAs. Yes. I believe that the problem with the MHRTC is there needs to be some due process given to the individual prior to their names being put on any list. And at present, there is no money to provide such due process, as the department is considering funding for such a process to ensure this can happen with MHRTCs, or perhaps folding it into another registry. And that's correct. Thank you for that, Mark. Got a couple more people typing. Andrew said, I agree, Mark, not only some kind of regulation and monitoring of the certified individuals, but also some kind of appeal process for those folks to have the opportunity to straighten out errors. David McCluskey has said, designing a system for reporting individuals that could potentially remove a license should be looked at carefully. This requires establishing a board, which is an extensive process to manage. Also, there needs to be protection for agencies from liability and required reporting. We should look first at existing rules to see if there is a current procedures to get at this. Also, could we look at the actual situations that we know are occurring that a registry could prevent? What are the issues? I think you raised some good concerns, David. Thank you for that. And you're right. I mean, it's, as Mark had pointed out earlier as well, I mean, it's not kind of this quick and easy process. You do have to make sure that there's the due diligence on all sides, for protection on all sides. And obviously it is a process that doesn't come without its own expense. So, but again, I think this is an opportunity to look at recommendations around that as well. Other thoughts, comments? Where do we go from here? Great question, Grace. So, just a little update about where we are. You'll see where we're starting to put on the left side of the screen the website under the Notes 5 box, where we're starting to put some information through this process. From the first meeting, we're pulling out themes. We also asked people who were not able to attend to respond to those same questions and send their comments, which we have gotten comments that way, and we appreciate people taking the time to do this. Actually, I want to say with this whole process, we really appreciate everybody's interest and passion and time, because we know everybody's busy, and we know that many of you, as we do, feel that this is really important for us to take a look at and figure out how do we best move forward here in Maine. So we're pulling out the themes of the initial feedback that we've gotten. We've been asking for individuals to let us know if they're interested in serving on an advisory committee and also the subcommittees, and we've been getting lots of feedback for that. So we're going to be setting up meetings in early December. We're kind of culling through to make sure that we have good representation across various different stakeholder groups for those. And we'll be putting that information on the website and also sending things out as well. If you are not getting information as we send things out, we're kind of creating like a listserv type thing. If you're not getting information and you would like to, please contact myself or Janice Daly, or send an email to the MHRTC redesign.dhhs@maine.gov. That's the email that's in the Notes 5 box. Any comments that in this whole process, we're using that as a good place to capture things. So ideas that come up, you know, a situation comes up and you think, oh, this ought to be addressed as we move forward in this process, send us an email and let us know. a couple other things I wanted to let you know that we're doing as well, and then I know there's a few other comments, is Muskie's pulling together a crosswalk for us, looking at other similar type case management services here in Maine to see whether it's through children or substance abuse, what are some of the requirements, what's different. One of the things that we mentioned was the issue of reciprocity, and so it's helpful to kind of take a look at what the current status is with that. Let me check a couple of the other comments here. Mark Joy said, David, the issues I've come across are things like MHRTCs having sexual relations with clients, then getting fired, then seeing them pop up in a different agency using their MHRTC, and there currently is nowhere to track that. If they were licensed social workers, their license would likely have been suspended or revoked. Yes. Catherine Brilliant said, agree, Mark. Those incidents must have a place to be reported. Many agencies are not even calling for a reference. And if it's stated that we wouldn't hire again, I see them hired at agencies. So, yeah, and it sounds like that's one of the real concerns. And we've heard that, as you all have known, for many years. And so, we're strongly hoping that we can figure out some ways to address that, not only through the registry process, but also are there some other kind of processes with being able to maintain your MHRTC certification, looking at that Good for Life status. So, but again, for next steps, watch your email, look at the website. We'll be posting more things. We'll be pulling those committees together to begin doing some more work. I would encourage you to look at the report, look at the matrices. As you look more and have ideas or other questions that you'd like, can you find out more about this? Send it through that email address and let us know, and we can, or if there's something you think Maine should look into, or, as I said earlier, not look into, please, more comments on that. So. All right, any closing comments? One, thanking for, appreciating the opportunity for being involved in the process. And again, we really appreciate all your involvement. Your help with this is vital. So everybody's help will help us build a stronger system. Thanks so much for participating in the webinar. Thank you again, Kimberly. We appreciate your presenting that information. It was very helpful.
It was great to be here. Glad to be a part of it.
Thank you, everybody.